Hello, everybody. Thank you for joining us today. We see that we have some people that are still joining. Thank you, and welcome. Okay, so let's get started. In today's session, we will be doing our session 3 of our Learning Collaborative on Health for All, Increasing Inclusion for People with Disabilities. And this session today is brought to you by the National Center for Health and Public Housing, and we're also collaborating today with NOHA, which we will be providing a brief introduction later on in the slides. So this is just a kind reminder to all participants that your line is muted upon entry. Please make sure that you also engage in the chat if you have any questions. Please raise your hand if you would like your line to also be unmuted, and this meeting is also being recorded. The slides in the recording will be sent to you all via email after today's session as well. This is also some information about NCHPH. The mission of NCHPH is to strengthen the capacity of federally funded public housing primary care grantees and other health center grantees by providing a range of training and technical assistance. And also the information presented today or the content and conclusions are those of the author only and should not be construed as the official position of policy, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. So for the speakers today, we have Dr. Kevin Lombardi, who is the Manager of Policy, Research, and Health Promotion at the National Center for Health and Public Housing. We also have Candace Sue Hohen, who is the Education Director at NOHA. And we also have Dr. Jose Leon, who is the Chief Medical Officer, and myself, that I will be helping in facilitating today's session. My name is Fide Pineda Sandoval. And here we have the data. There were over 1,300 federally qualified health centers that serve to over 30.5 million patients, 483 FQHCs that were intermediately accessible to public housing, and 107 public housing primary care grantees that served to over 935,000 patients back in 2022. And right here, we also have a map that shows the health centers that are immediately accessible to public housing. You can find this map in our website at nchph.org. And now I will pass it on to Dr. Kevin Lombardi, who will be going over today's learning objectives and other presentation information.
Hi, everyone. Dr. Kevin Lombardi here. In our third session today, we will engage collectively with data, research, and case studies which outline the challenges in providing oral health to individuals with different types of disability. We'll be giving an epidemiological and public health overview of the topic. It seems I was muted. Hi, everyone. In our third session, we'll be engaging collectively with data, research, and case studies which outline the challenges in providing oral health to individuals with different types of disability. This will include an epidemiological and public health overview, a review of promising practices, and an overview of recent publications. My training is internal medicine, and oral health is something we have a very cursory involvement with in medical school and in residency. Our dental colleagues take care of most of that. But from the perspective of a medical provider, we are often referring folks to dental specialists. And in the event of a disseminated infection with a infectious etiology that is in the mouth, we are the folks that are taking care of that afterwards. For individuals with disability, oral health care is particularly important, and it is a challenge for our health centers as well to provide these individuals with different types of support. And for those of you who work with individuals with disability, the reasons are are quite varied, but are often due to the diversity of the patients that we are seeing. Individuals with different mental capabilities, behavioral problems, and mobility problems all have unique challenges for providing oral health care. And this can range from difficulty following instructions to at a dental office or at home. Anxiety caused by developmental disabilities can make it very uncomfortable for certain folks to receive dental treatment. Mobility problems as well, and even issues that are more complex, such as neuromuscular problems that can affect the mouth and make it difficult for individuals with disabilities to even open their mouths or provide their own health care. If we go to the next slide, please, I will give a short introduction to some relevant issues related to our residents of public housing and pass it off to our colleagues. Next, please. And of course, one of the main takeaways from this session should be rely on your colleagues. We have an amazingly diverse group of folks here with diverse positions, professional acumens, and so forth. And at the end of the session, we'll be having a collective discussion on the topic. So I encourage all of you to be as loud as you can about your perspectives and opinions on the issue while being respectful and collaborative at the same time. This is a learning collaborative. So we will be relying on that aspect of the educational of the session disproportionately compared to a classic webinar type format. Next, please. And some information on the rigor of the systems that we use to provide you with the material you'll see today. Research and clinical resources, guidance and recommendations, and support and consultation resources are all vetted by myself, my colleague, Dr. Leon, and the rest of our team to ensure that you're getting the most accurate, up-to-date, and scientifically rigorous recommendations and information. Next slide, please. For individuals with disability, intellectual, physical, emotional, the social determinants of health is an extremely important grounding because of the disproportionate impact that the SDOH has on this population. Issues of housing, access to resources, and safety are particularly important for our individuals with disability because of their inherent vulnerabilities. For those of you who use the SDOH in your work and would like to read some more into its theoretical foundations, I'd recommend taking the World Health Organization's conceptual framework. It's a great way to understand your role in the SDOH continuum and our role as professionals in supporting the equitable provision of healthcare to our patients. Next slide, please. And of course, some more information on the social determinants of health itself. Just briefly, the social determinants of health gives us an understanding of the environment and its impact on the patients in a holistic and detailed way. Next slide, please. For providers, not giving holistic support to patients and holistic support, including oral health care, other support as well, is a significant contributor to burnout in physicians and practitioners in health centers. According to the American Physicians Survey in 2022, 6 in 10 physicians have little to no time to address the SDOH in the exam room, and 89% indicated lack of staff to address the SDOH. Burnout related to SDOH is a significant issue that contributes to our retention and recruiting issues at health centers, and making sure that you're comprehensively addressing your patients' needs is a great way to comprehensively address the needs of your staff as well. Next slide. And let's look at some quick data on how disproportionate individuals with disability are represented amongst folks with public housing and HUD assisted. And let's look at the data that HRSA has collected from its health center program surveys. in particular the health center patient survey. What we can see is from some of the questions that ask about self-care, for individuals that are struggling with self-care, such as washing and dressing, HUD-assisted and public housing individuals are nearly twice as likely to indicate that they are challenged in those areas. Next slide, please. Difficulty with eating, and that is the physical act of eating, bringing food to one's mouth. We can see that 17.5% of our public housing patients have that issue. That is a significant physical disability, which also has significant implications for oral health as well. Next slide, please. And falls. We can see that our HUD-assisted patients are much more likely to have experienced a fall that created an injury that limited their regular daily activities or caused them to see a doctor or health professional. Next slide, please. So residents of public housing are more likely to rely on home visits than other demographics. For individuals with disabilities, home visits are a great opportunity to give them care and surmount the barriers that are often present that prevent individuals from coming to the health centers themselves. As one can imagine, with someone with physical, mental, or emotional disability, going to a health center can be a significant barrier. And what we've seen is our health centers have been very effective in using CHWs and other health professionals to provide home visits. Patients at PHPCs are nearly 2.5 times as likely to have received a home visit or relied on a home visit for care. So this is home visits are a promising practice for residents with disabilities. The next slide, please. Now, let's talk about the format for the rest of our session. In 2 seconds, I will be passing out to Candace Owen, and she will be telling us a little bit about oral health in patients with disability. After her presentation, we'll be engaging in a collective discussion together. And what we'll be doing is I will be doing a podcast style interview of her and my colleague, Dr. Leon, on the topic. And we'll be encouraging other folks to be involved in the discussion as well by raising your hand or participating in the chat. So at this point, I'll now pass it off to Candace. And Candace, thank you so much for your time and your service to individuals with disabilities. Could we pass the ball to you?
Sure. Thanks so much, Kevin and Jose, for having me, and everyone at the National Center for Health and Public Housing. As mentioned, my name is Candace Shue Owen. I am the Education Director for the National Network for Oral Health Access. We call ourselves NOAA. You can move on to the next slide. A little bit of background on our organization. We are a nonprofit membership organization that was founded in 1991. We support dental professionals working in federally qualified health centers and the rest of the safety net. And our membership now includes over 5,000 dental professionals, medical team members, supporters, and partners. And pictured there on the right is the founder of NOAA, Dr. John McFarland, working with a dental assistant. Next slide. Okay, so, and you can advance to the next slide, thank you. Just a little bit more about our organization. Like National Center for Health and Public Housing, we are a HRSA National Training and Technical Assistance Partner. They call us NTAP. So we receive funding from HRSA to provide support, training, education, resources to health center dental professionals. And so this is just a list of some of the resources that we have and our website and a general email account if you ever have any questions when it comes to dental programs, oral health, or anything in that realm. Next slide. So these are the objectives for my presentation today. We'll talk about some common oral health conditions that we see in people with disabilities, identify some strategies to promote more inclusive oral health care for people with disabilities, and also share some best practices. Next slide. So a little bit of level setting for myself. I am a dental hygienist by training, and before I was working with NOAA, I specialized in patients with developmental disabilities in a clinic that exclusively saw patients, children, adults, and beyond that had disabilities and provided oral health care to them. In 2020 to 2021, the National Survey of Children's Health, they do break down the survey a little bit to talk about children with special health care needs. And a lot of scenarios when we talk about data for disabilities, they really focus on children. So that's what this data is. Over 20% of children have a special health care need. 2.7% of children with special health care needs have unmet dental care needs compared to 1.4% of children without special health care needs. And the most common reason for unmet dental care is cost and appointment availability. 20.6% of children with special health care needs had no preventive oral health visit in the past 12 months. And 19.5% of children with special health care needs had one or more oral health problems in the last 12 months. As well as according to Special Olympics, when they're including adults in the special health care need populations, oral health is the most unmet need for patients with developmental disabilities. Next slide. So this slide shows some of the oral conditions that are most commonly found in people with disabilities. Malocclusion is just the word for crooked teeth, so having crowding or something like that, which makes it really difficult to maintain oral health care because it's harder to fit a toothbrush in. You might miss a lot more areas if your teeth are crowded or crooked. Periodontal disease, which is just the advancement of gum disease. So gum disease is known as gingivitis. If that progresses and it starts to affect the bone that holds in the teeth, then that's called periodontal disease or periodontitis. Enlarged tongue is called macroglossia, and that's just when the tongue is really large, makes it difficult to really get in there with a toothbrush, especially if you're reliant on a caregiver and the caregiver needs to brush teeth for the patient. It makes it difficult just because that tongue is in the way and fighting. But also with a tongue like that, it does create opportunities for malocclusion or crowding because the teeth are constantly being pushed on by the tongue. And tongue thrust is also something that we see a lot, and that's when that behavior or that mechanical behavior of the tongue being pushed out. Food pouching is common for patients with particularly intellectual or developmental disabilities. That's just when food is being housed and left in the cheeks. And this can cause irritation and some development of some problems just with the tissues around the teeth. Heavy plaque and tartar accumulation is common here. Erosion, that's from acid. So if you have a patient that has some GI problems, and then you might have some erosion on the backside of the teeth. Increased risk for cavities. This comes from challenges in the ability to brush and maintain home care, reduced visits to a dental provider, and then also the diet is often not very conducive to an anti-cavity diet because they're eating a lot more soft foods, which tend to be carbohydrates, which are more conducive for cavities. Tooth grinding is also known as bruxism, and this is often just a mechanical behavior of grinding your teeth up against each other throughout the day or while sleeping. This brings down the level of the teeth. It can cause some problems with the jaw and also some challenges just with sensitivity of the teeth. Oftentimes we see with patients that have developmental disabilities that there's a delayed tooth eruption, meaning that the teeth don't come out in the normal time periods that we see in general. And so if there's delays, then you might have a lot of primary or baby teeth still in the mouth, even in an adult. Gag reflexes are really common in this population, as well as GERD, which is just like GI, and then also increased risk for trauma from falling or any type of behavior that may increase the risk for teeth to be damaged, biting the tongue or cheek or lip, and things like that, that can be things to look for when you're looking in the mouth for a patient. Next slide. So this slide here are just showing some of the images and what we're seeing when I talk about some of the oral conditions. So on the upper left, where the mouth is slightly open, that's from a tongue thrust. So you can actually see when you look at the sides of the mouth that the teeth are closed all the way, but there's a gap at the front and it looks like that they're open. And that's because the tongue is constantly thrusting out. So it's caused some malocclusion of the teeth, forcing the teeth to flare out. And when you have that opening like that, then you're at risk for dry mouth, which can then lead the risk for cavities and things like that. The middle picture on the top is an example of an enlarged tongue. And then the picture on the upper right, that is erosion. So you can see how the teeth are no longer white on the backside. So this is the palate when you're looking up at the palate of your mouth, and how yellowing and like the cupping, and that's from erosion, that's from acid coming up in the mouth. And that can just eat away at the enamel, and then you have just the other surfaces of the teeth showing that are much more sensitive because they're not covered by enamel, and that can just cause some problems for the patient. Also, that yellow area of the tooth, that's called dentin, and it's also much softer than enamel. So if it's exposed, you're running the risk of cavities as well. The picture directly below that, that's just an example of periodontal disease. So you can see how the gum tissues are really inflamed, they're red, there's some bleeding going on, and that's from gum disease that has progressed over time. The lower middle picture, if you're really looking at the teeth there, you might just kind of say that there's some gum disease going on, but when you really look in at the picture, there's things covering the teeth, and that is tartar. We call it calculus in the dental world, and this is plaque that has calcified and hardened over time. And this is because there's not brushing going on. And a lot of these patients are reliant on a caregiver to brush their teeth, which often doesn't happen, or it's very poor and not done well. And so that leads the risk for that tartar to build up on the teeth. It's hard and dense, it's irritating, holds a lot of bacteria, so it's really irritating to the gums, the bone that hold in teeth and whatnot. And then that lower left picture, that's an example from grinding. So grinding your teeth just really aggressively, and you can see how the teeth are kind of chipping away and how flat they are on the bottom. And that's only because you just grinding your teeth up against each other just continues to weaken them and then pull some of that tooth structure away. Next slide. There are a lot of other factors that really complicate oral health care for patients with disabilities. Firstly, there's a lot of behaviors. So sometimes there's involuntary movements, as we know, repetitive behavior, or a lot of body movement, which can make it difficult to provide oral health treatment, much like any other type of medical care. And so being mindful of those movements, especially in the dental world, we have a lot of water, we have a lot of sharp instruments, which can make it difficult. But training is really critical here to be sure that you're mindful of your own self as a provider, but also of the patient's safety as well. Dexterity is an issue. If they're not able to hold a toothbrush, then it may make it really difficult to brush and do that care at home. And so again, comes in that reliance of a caregiver or a parent to take care of the patient. When we're thinking about dexterity, if it is a patient that is able to brush on their own, but maybe their hand coordination isn't great, or they can't hold on to a really thin toothbrush, then there are some adaptations that can be done there. We see in a lot of scenarios, you can use like a tennis ball and poke a hole in the tennis ball and put the toothbrush in there. It makes it a lot bigger. You could also use a bike handle and get one of those grips, stick the toothbrush in there. It makes it just a little bit thicker and easier for brushing and to hold and wrap your hand around the toothbrush. As mentioned, there's a lot of risk for trauma. So when we were seeing patients in our clinic, in a lot of cases, they would come in and have chipped teeth or damage to their cheek, or loose teeth because of falls and things like that. And so really keeping that in mind as well. Like I said, that malocclusion or the crooked crowding teeth makes it really difficult to clean. And so we see a lot of periodontal disease and gingivitis just because there's challenges in really being able to get those teeth clean. Soft diet in a lot of scenarios for patients with developmental disabilities, in some cases, they're not even eating a food diet. They're having some sort of like liquid diet, and you're just increasing the risk of cavities here because there's not that saliva moving around to really clean the teeth. Saliva is kind of a natural cleaner for your teeth. So if you're not chewing or eating hard foods, that can create some risk. But then also carbs, sugar, high sugar diets, those are what are conducive to an environment that cause cavities. For a lot of these patients are multiple medical visits, and so it's difficult to prioritize where you're going to go. And so if you have a lot of medical visits, it really is a strain in some scenarios to have to also tack on a dental visit. And if they have a lot going on, then you're talking multiple dental visits. And so being accommodating and mindful of what you can do for the patient is helpful. A lot of them are on multiple medications, which can have some oral health side effects like dry mouth or different type of taste in the mouth, which affects their desire to eat and engage. We do see high incidence of abuse with patients with developmental disabilities, which is really difficult because you can see that often manifest in the mouth when you're seeing those patients. Then, as mentioned, a reliance on a caregiver to do oral hygiene, which again isn't great to ensuring that the oral hygiene is getting accomplished at home. Next slide. In many situations for patients with disabilities, there's access challenges, and they're all very similar to access issues for medical providers. It's all the same for dental professionals as well. In the dental world, there's really a lack of training when it comes to providing care for patients with disabilities. In a lot of situations, they just get referred to the operating room or to the hospital. And so to even get basic dental care like a cleaning, a lot of these patients are having to get put under just to get that care accomplished, which in many scenarios is overkill and isn't necessary. But if you don't have training as a dental professional, you may not feel comfortable. And that kind of feeds into the attitudes of dental professionals and the willingness to provide care to this patient population. Financial reimbursement is a common thing that we see with patients with disabilities in dental care. Because the dental visit may take longer, dental professionals would like to get reimbursed more for the care that they provide. In some states, there have been some improvements to where dental professionals can get reimbursed for a behavior management code. And so this gives an additional tacked on reimbursement in addition to the different, like getting reimbursed for the other services. So it makes up for the lost time that is perceived by a lot of dental professionals. But that's not the case in every state. And so therefore, that just continues to feed into that attitude and just referring over to the hospital instead because of lack of time. Of course, transportation to healthcare is always a barrier, but particularly if you are unable to drive or you rely on somebody else, attending visits can be difficult. As mentioned, there are often other health priorities that come ahead of oral health care. And so being able to really discuss the connection between systemic and oral health is helpful. Many dental spaces lack accommodations for patients with disabilities. So this includes wheelchair access, enough space for the chairs or for caregivers. The length of appointments can be challenging as well. Unlike some medical appointments, dental appointments usually last an hour, and so that can be difficult for the patient as well. And then, of course, if you're unable to meet the needs of the patient in the dental clinic, then where do they go? And as mentioned, that often goes to the hospital. Next slide. And so thinking about the role of the health center, many of the patients with disabilities may have financial barriers or be on Medicaid. And so ultimately what we always tell our health center dental team members is that you will inevitably have someone with a disability in your health center. And so being prepared to support that patient, engage with them and their caregivers, and help that care navigation to ensure that all of their healthcare needs are being met, including oral health. Next slide. And so just some recommendations to promote an inclusive dental clinic environment. Really encourage if you have a dental clinic as part of your health center, thinking about how can you accommodate patients with in wheelchairs. And so there are different ways to do this. I mean, there's a Hoyer lift, which is a picture on the right, and that is like a lift that can move the patient from the wheelchair over to the dental chair, and then you're able to provide care there. It's really challenging to provide dental care when a patient is in a wheelchair. Sometimes you have to do it. They can't be moved out of the wheelchair safely. And so providing care that way and being prepared to do that, but also understanding how to safely transfer patients if they can be transferred to the dental chair. There are some really cool technology advances. So there's wheelchair recliners where the wheelchair gets like hooked into this recliner, and that's what that image is there on the left, and it tilts the chair back. And so then you're able to provide treatment, dental treatment in the wheelchair without having to worry about breaking your back over to see the patient's mouth, but they're able just to lean back like any other dental chair. Of course, as we know, being ADA compliant, making sure that you have ramps to the building, the width of the doors. This includes the width of the doors into your dental operatories or your medical clinic rooms, that they're accommodating for the patients. We always talk about ensuring that there's inclusive language on your paperwork or anything that the patient needs to look at. If the patient comes in and they have a caregiver, it's still important to address directly to the patient. Oftentimes we see that they just immediately start talking to the caregiver, but the patient is able to communicate, and there's just this assumption because there's another adult with them that they can't understand, or that the caregiver is the one that needs to have the conversation. So always start by talking directly to the patient, but then also making sure that your language is inclusive, that we're not using terminology like disabled or wheelchair bound, but person first language, and that everything is inclusive and promotes dignity and respect for the patient. Training is really the only way that I see access for developmental disability and beyond to increase access to care. If the team members are not trained, then that will just continue to create limitation and barriers to access. And so this goes high level up to academia, but within your organization, thinking about how can you train your team on treating patients with disabilities. And so this includes talking about some of these common oral health conditions that you'll see, some of the medications and the side effects that may affect the mouth. How do you accommodate the patient and having space for them in the clinic, and knowing when it is appropriate to refer to a specialist. And then finally, considering the level of stimulation in the waiting rooms, your operatories, and that, again, it's inclusive and really allows for patients to be comfortable in your room. Next slide. These are some clinical recommendations as providers. And so I think primarily establishing partnerships with your community. This includes local hospitals. Consider hospital privileges for your dental team so patients can receive care there if that is really the only option that you have. But then also getting a relationship between medical and dental so that when you have a patient with a disability, you can provide whole person care. You're able to collaborate with your dental counterparts and talk about ways that you can help manage each case. Explore some community resources. If you have a lot of patients that come in with disabilities and you just don't have the accommodations for them when it comes to dental care, thinking about partnerships with local dental schools, because many of them do, and they have to have accommodations so that so the students get training and experience seeing this patient population. There's also a lot of dental clinics throughout the country that specialize in patients with disabilities, and so creating some referral partnerships is helpful. Again, as mentioned, equipment and resources to treat patients with disabilities, training the dental team and the medical team. Increased training leads to increased comfort. Next slide. So when it comes to supporting patients with disabilities, thinking about what can you do to make appointments more conducive and more available to them. So this could be appointment times. If you have a patient that says, or you have someone making an appointment and they have a disability and they disclose that to you over the phone, maybe to asking what time of day is best for you, How long of an appointment are you able to manage? Even if they come in and it's supposed to be a 1 hour dental appointment, but they can only stay for 30 minutes, being able and flexible to help manage that and help them come back if that is something that they would prefer to do instead. We see a lot of patients with disabilities that are on medications, and so sometimes they do better during the day than in the afternoon. And so really working with them to find a way that works, something that works best for them. Really, and as mentioned, treating the patients with respect and dignity, talking in person first language, really supporting them and finding a way to accommodate them the best that they can, and being mindful of behaviors and the way that we're acting around patients with disabilities. It's important that you have adequate staffing ratios, enough people who are trained so that they can provide the highest quality of care to these patients. Focus on developing trusting relationships with the patient, and also providing clear plans of what to expect during the dental visit, and also very clear post-operative instructions. I think in general, most people here can talk about some nervousness or fear when it comes to seeing a dental provider, and it's no different for any other patient as well. So being clear and providing clear expectations, this is what we're doing during today's appointment. Do you have questions? And talking with them along the way. Next slide. This is something that we often see taught to our students when it comes to developmental disabilities, or any disability, really. It's the 4 C's, and being committed, calm, confident, and consistent. And so these are really helpful in just thinking about the way that we treat patients. And really, it's not just exclusive to patients with disabilities, with any patient as well, being committed to their care, staying calm, being confident in your skills and your ability, and then also being consistent and making sure that there's consistency across the board in their healthcare. Next slide. So NOAA has a listserv, and this is just a group email thing for our members. And I went ahead and went on there and asked, what are some strategies or promising practices that you have when treating patients with disabilities in your clinic? And these are some of the things that came in. So these are promising practices from health centers that are actively doing the work now. Many of them have sought funding from outside entities like foundations to support increased training for patients with disabilities so that their team members can be more comfortable, but then also to support equipment. So this includes like those wheelchair transfers or the recliners to support that type of care. Many of them do advocacy work for increased reimbursement rates, as I mentioned, or to be able to be reimbursed for behavior management. This just offsets some of the extra time that you might need for an appointment. As mentioned, many of them are partnering with local hospitals or anesthesia facilities to deliver care. And some of them have, and this is something that I did when I was seeing these patients, was that we created these 15-minute desensitization appointments. And essentially what it is if the patient was uncomfortable, or maybe it was their first dental visit in a while, they'd only be scheduled for 15 minutes and we wouldn't deliver any type of service. It was more just sitting with the patient, introducing ourselves, showing them all the different equipment that we use, different tools, and then just getting them comfortable with the dental clinic environment. And they would come like every week to do this. And I had patients that would start off that way, and I would see them for about a month, and they would come just for 15-minute appointments. And then over time, they increase trust with you, and you're able to actually complete an entire dental visit at some point. And there are a lot of specific trainings for dental team members and medical providers on oral health for patients with disabilities. And on the next slide, I listed out some of those resources. So the University of Pennsylvania has a certificate for treating patients with disabilities, and that's a great resource. The Special Care Dentistry Association has a lot of excellent handouts, webinars, and resources, not just for dental professionals, but medical as well, and caregivers and case providers. And then the University of Washington has some really excellent continuing education and fact sheets available there as well. Next slide. My contact info is there. I also included contact information for Dr. Irene Hilton. She's our dental consultant. We often tag team when it comes to inquiries, so feel free to email either one of us, and we're happy to answer any questions that you have.
Okay, fabulous. And Fide, I'm going to take over if that's okay. Fide, could you go back to, if you remember the last slide of my slides that had the description and instructions for the discussion section. And before we kind of open things up, Candace, I wanted to ask you a little bit about, well, first for our participants, for those of you who have not already, if you could please put into the chat your what health center or organization you are coming from, and what are your roles, responsibilities, and so forth at that organization, please. And Candace, I wanted to start briefly with you because I noticed from the letter salad that you have at the end of your name that you're a dental hygienist, but you have training in public health as well. And I was wondering how one lives that circuitous professional path, and it seems like you've landed in the perfect place for yourself. Could you tell us a little bit about what inspired that journey and what got you to where you are today?
Sure. I oddly have always enjoyed dental visits ever since my youth. So I had a really great dental hygienist as a kid who really encouraged me to continue forward. And so I went to hygiene school, got my bachelor's in dental hygiene, and both of my parents are immigrants from China and Taiwan. And so many of times I feel like I've been in public health for a long time in my career because of just navigating healthcare with them and supporting them through that. And so it just felt really natural for me to go into public health and really to focus on equity. And so, I decided to pursue my master's in public health. And then I also have my master's in dental hygiene, where I taught for a really long time dental residents, medical students actually on oral health and interdisciplinary care. And so it was just kind of a natural way there. Yeah.
Okay, so there's some more background for our participants. We have someone who most certainly knows what they're talking about here, as far as the systems and structures that that contribute to this issue. And I see we have a hand, Shauna. Would you like to tell to involve in the discussion?
Hi, yeah, thank you so much. That was a great presentation. However, I just wanted to know what are your thoughts on, we could say, delay in treatment and delay in care when it comes to oral hygiene. So, what we want to do at State Healthcare is build a new medical management system. And with that, we wanted to provide, we could say, testing kits, like for H. pylori, just so it could decrease the incidence of disease or transmission from physician to patient, patient to physician. So I wanted to know, what are your thoughts on, we could say, prophylactic or preventative treatment before, someone sits in the dentist or gets an examination or even a clinic?
For clarification, you're wondering prophylaxis as far as like antibiotics prior to a medical treatment?
Yeah, antibiotics and also testing before a dental procedure, just to decrease the incidence of disease for transmission from you could say, dentist to the patient or the patient to the dentist. Because, of course, if you're a dentist, you're supposed to have great oral hygiene. But, with the instance of disease, how does that delay care as well? Because I know some people may be leery because not everyone's teeth are in the best condition. You showed some diagrams there, and I'm like, well, my first set of teeth weren't like that, but my second set of teeth do have those ridges. And I've always, it was instilled great oral hygiene in our family. So I'm just wondering, do you think that's a great idea to have like a preventative treatment before? Of course they have to be tested. If they're negative, then fine. But if they're positive, and sometimes the physician may not know. So, our new model here, we wanted to decrease the incidence of disease. And I think that's why there's some hesitancy in oral hygiene and care from, we could say, the physician's perspective or the dentist's perspective.
If you don't mind, I can briefly give a physician's perspective on this, Candace, and then I'll allow you to involve yourself if you have something to add. But this is really an individual decision based on the patient. I know with in particular, the recommendations are different for different disabilities. But for example, with our patients with Down syndrome or heart valve issues that are related to their disability, chromosomal issues, and so forth, they're often at increased risk of cardiac disease, cardiac infections, and so forth, especially from pathogens such as strep viridans, which is a very common component of dental caries. For patients like this, if their oral health disintegrates or if it becomes an issue, the dental infections such as a strep viridans can very easily become a disseminated infection, deposit itself in a valve, a replaced or a damaged valve, and become a cardiac issue that is very difficult to treat. When these folks have specific cardiac infections that are related to this, and they are very often patients with Down syndrome, it becomes a huge ICU internal medicine issue when it could have been a preventative issue. I know there have been some studies in using prophylactic antibiotics with these individuals when there certain risk factors have been identified, but it really depends on the specific disability and the specific patients. That's my perspective as an internal medicine physician. From the dental colleagues I have spoken to, my understanding is they take that on a case-by-case basis as well, depending on their knowledge of the patient and the condition. But I will ask my more in the know colleague about her opinion about that.
Yeah, I think it's similar. It's really case by case. And in most scenarios, like it would be something to consult with their physician. And so reaching out to them and seeing what their recommendation is. We've seen patients with the same condition, and two physicians have different mindsets on what they want to do as far as antibiotics prior to dental care. But as mentioned by Kevin, it is important for them to get oral health care. And so finding a way to navigate it rather than delaying and saying, like, we'll manage that later, finding what antibiotic is necessary if needed, and then getting them the dental care. Because if their oral health is poor and there's a lot of infection going on, it could progress and it could affect other parts of the body.
Hmm. So with individuals like this, an endocarditis can be it can be an ICU visit. It can be it's extremely expensive to treat. We're talking about weeks of antibiotics and so forth. And these are all issues that in many cases can be prevented with appropriate oral health care. Very challenging to provide oral health care, but the cost to benefit ratio here is significant. Providing this comprehensive care it can save, in some cases, hundreds of thousands of dollars and significant pain and significant stress and anxiety for family members and the patient as well. For those of you who practice in internal medicine or in an ICU, when you have an individual who has a emotional or intellectual disability, an ICU visit is terrifying to them, even more so than a patient that does not have that disability. So oral health is a great way to prevent those adverse human experiences. Shauna, do you mind telling us a little bit about yourself, where you come from? I appreciate that question.
No problem. I am a health service administrator. That's what I have my bachelor's degree in. I have some experience in, we could say, primary care and multi-specialty, just work experience. I acquired a telehealth company at the end of 2020. However, I didn't really like the way telehealth was being advertised, so I decided to take a different cognition on it based on my experience in medicine. So we wanted to build a new healthcare system, and that entails implementing an NL11 code, which is 211, designated for health, social, and human services, residential care facilities, Since the Centers for Medicare and Medicaid Services have a health home model, we really wanted to live by that and create new housing with FDA approved spring water in comparison to a reservoir. Then we have an on-site medical spa, which specializes in dental care, podiatry, dermatology, nutrition, pharmaceutical needs, an actual telehealth point, and a general hospital. So it's partnering with major hospital systems so that we can establish these new facilities.
Well, I can see from my colleague's eyes that he's very interested in what you said, and I'd love to hear some more about it. Would you mind if I toss you an email?
No problem.
Well, it's great to see so many folks are focused on comprehensive care, and I'd love to hear more about that model. We are getting close. So if there are hands, please put hands up, and I have a couple of questions as well. And Dr. Leon, if you have something, please do interrupt.
Thank you. Thank you, Kevin. Candice, you mentioned something that is really important, and sometimes not only physicians, but also dentists have not been trained to treat, or provide care to patients with disabilities. I've seen some surveys showing that only 38% of clinicians, and it's about the same percentage for dentists, who have not received training, and they are unaware or unfamiliar with any type of care for people with disabilities. So you mentioned a couple of trainings, and you mentioned some resources. Is there anything in particular that you would like to recommend, for those attending these learning collaboratives, so they are more familiar to establish a program or a curriculum, to show their colleagues?
Yeah, I think the University of Pennsylvania certificate is a really great starting point because it provides an overview. It does go like a little bit more in depth. So if you're a dental provider, that's a good one. But I think that the most important thing is just like providing exposure over time. So if you have a local Special Olympics in your community, that's a really great place to start. They do a lot of health screenings, and so you can volunteer and participate in things like that. And just constantly exposing yourself to people with disabilities and learning their behaviors and the conditions that they face and the struggles that they have and barriers. And I think that helps. That a lot of it comes down to academia and exposing the new healthcare team with the resources to actually provide some hands-on experience with people with disabilities. But as established providers, I would say starting small, do some online trainings, and try to go out into the community and find ways to work with other team members and other folks that are seeing this population.
Thank you, Candice. And just a follow-up question. Even though we are talking about dental care, many of our patients are also being seen by CHWs or health educators. And one of the issues that we've seen is sometimes there is some kind of difficulties. These professionals are not familiar with dealing or caring people with disabilities. Stigma is another big concern for people with disabilities. So is there, or are you familiar, even though I know that your expertise is in dental care, have you seen any other training for other professionals, in regards to how to provide care to people with disabilities?
I know that the University of Washington has a really robust program for people with disabilities, so that might be one to look into. And then also, I've said Special Olympics a lot, but they do have like an online learning platform. And I've only seen the oral health section, but I know that there's others, so that might be something to look into.
Thank you, Candice.
Yeah.
And before I give you the opportunity to close things out, Candace, I did want to add one thing, is that from my own experience, not in the dental field, but in the medical field with patients with disability, is these can often be the most rewarding relationships clinically that you create. Individuals with disabilities are often so warm and welcoming of appropriate clinical care and appreciative of it. And individuals with disability are an important source of diversity in our society, and working closely with them gives insight and depth into the human experience that we really can't get elsewhere. So it is a privilege to serve them, and thank you for providing this information, and for our colleagues for their service to their communities. Candace, is there any final words before we pass it to Fide?
No, thank you all so much for having me. And again, applaud you all for your work. And if you have any questions or follow-up, feel free to reach out. Thank you.
Thank you. Thank you so much. And now I will do some final announcements here. All right, so our next session will be next week on Monday at the same time. And in this session, we're just going to be going over our conclusion and some case studies engagements that we're going to be doing during the presentation.
One addition, Fide, the case studies will be program interventions, not clinical interventions.
Okay, perfect. Thank you. And then this is just another reminder also to please complete our post-evaluation survey. Your feedback will be greatly appreciated for us so that we can make any improvements as we continue to complete this learning collaborative. And again, here is also our contact information. If you have any follow-up questions for our speakers today, you may contact Kevin Lombardi at kevin.lombardi@mgt.com, or you may also contact me at fide@mgt.com or Dr. Jose Leon, and we will also be sharing the slides with you all shortly. Thank you all for joining today, and we'll see you next time.